All right, so we're dealing with a case that presents an abdominal radiograph of a skeletally mature patient. The first thing that stands out is the alignment of the kidneys. Unlike the typical lateral orientation of the long axes, these kidneys are projected medially. As we look closer, we notice that both kidneys appear to be fused at the lower poles, and there's an impression of them being pulled towards the midline, particularly at the level of the L4 vertebra. Now, this is quite characteristic of a horseshoe kidney, a common renal fusion anomaly. But let's not jump to conclusions just yet. The presence of fusion suggests we're on the right track, but we also need to account for other findings. We see two distinct calcific densities projected over the left renal outline. These are at the level of L3, which means we're dealing with calcifications either in the kidney itself or the renal tract. The sharpness of these calcifications leads me to believe that we're looking at renal calculi rather than other causes like phlebolyths, which are usually more centrally located and have a different shape. Given the projection of these densities over the horseshoe kidney, the most likely diagnosis here is renal calculi within the horseshoe kidney. Now, horseshoe kidneys are known to predispose patients to conditions like hydronephrosis due to pelviureteric junction obstruction or even recurrent infection, and these calcifications could easily result from stasis or chronic infection. Let's also consider what's not here. There's no evidence of hydronephrosis on this film, and the bowel gas pattern is unremarkable. So, we're not looking at an acute obstructive uropathy in this instance. At this point, I would routinely examine the rest of the imaging, possibly with contrast studies or a follow-up CT to assess any filling defects or renal obstruction. Calculi can cause all sorts of trouble, especially in anatomically abnormal kidneys like this, so follow-up is definitely warranted. This would be a case where we might anticipate questions from examiners about the differential diagnosis of calcifications within the renal tract. For example, they might ask about distinguishing features of phlebolyths versus renal calculi. Phlebolyths tend to be smaller, often with a lucent center, and are located outside the renal tract in the pelvis, while renal calculi are typically denser and more consistently opaque, particularly if they are composed of calcium. They might also probe further into how you would manage a patient with a horseshoe kidney and recurrent stones. In such cases, beyond addressing the acute stone, long-term surveillance and management for infection, obstruction, and tumor risk would be key points to cover. Wrapping it up, I'd report this case as a patient with a horseshoe kidney and evidence of calculi in the left lower pole, and I'd recommend further evaluation with contrast-enhanced imaging to assess for any obstruction. That's how I would present this case, walking through the findings, forming a differential diagnosis, and wrapping up with management. If you've enjoyed this session, be sure to stay tuned for more radiology cases and breakdowns like this. Don't forget to subscribe to Radiology Made Easy, your quick source for radiological insights.